Yeah, there's a lot to talk about with neuro-oncology, and I want to make it a little bit more broad-based this year. So I've added some things, so bear with me if I kind of get confused in my slide order. It is a big change for me. So apparently I have to tell you that you can use these for educational purposes. And I have to declare that I have a conflict of interest. I receive research support from this company in South Africa, which really just means they fly me down there so that I can go on safaris. Neurosurgery is not a bad gig. So a quick introduction to neuro-oncology, quite specifically from a surgeon's perspective. The issues related to how brain tumors present is quite age and location specific. And so we'll look at that, and I want you to get a sense as to what we can and can't do. And so hopefully there's half a dozen of you in the room, or maybe 100 and a dozen of you in the room who are brighter than me, who can start being researchers and come up with some solutions to our limitations. Because as a surgeon, I'm kind of tapped out. This is a little girl, and I have permission from her family to discuss her case. This is a little girl who came to my attention a year ago. No, almost 2 years ago. And she wasn't as big and bright as this when I first met her, but we're going to tell her story a little bit today because it touches on all aspects of neuro-oncology. So, yeah, about almost 2 years ago, she presented to me. 5 years of age, and for a very short period of time, she was losing her balance, she was falling a fair amount, and she was quite nauseated. And she came into the emergency department and had this CT scan, and Dr. Butcher showed you some CT scans, I'm sure, but what you might not recognize, and I'll show you, is this is abnormal. And this is the brain tumor in this little 5-year-old girl. And in children, which is the majority of patients I treat, the majority of the brain tumors that we see are in this location, the back part of the brain, in the posterior fossa it's called. So she went on to have this MRI, which demonstrates this tumor, sitting here in what's regionally referred to as the fourth ventricle, which is this fluid-filled space in the back part of the brain. It's normally a very small triangle, like that, but you can see how it's completely been filled by this large tumor that's trying to spill out of the fourth ventricle and down into her spinal canal. And so she has that tumor. So 2 days later, we took her to surgery. And after surgery, this MRI shows that we took all the brain tumor out. There's some swelling in the brainstem right here. She now has a normal fourth ventricle. And all of this surgery was done through a very small approach from the back of the head. She's got a scar, I'll talk this way around, a scar that's about that big. And all of the work was done just through the base of the skull there to reach up and take all of that tumor out. And it left her with some swelling in the brainstem, and because of that swelling in the brainstem, she has this eye that doesn't look straight. She's lost her conjugate gaze there, and she also had a lot of swallowing difficulties after surgery, so she needed this tube put in her nose so that she could get proper nutrition. This is what her tumor looks like. I don't have a normal brain slide, but let me tell you, this is an incredible number of cells on a slide. Very rapidly progressive tumor, very aggressive, and the pathologist told me that this is an ependymoma. In fact, she has an aggressive form of ependymoma. So this is the question that I get asked every month: why my child? And then they ask, is it because I live near power lines, is it because I live in Alberta and there's all that dirty oil, and why? And so, why? Well, because pediatric brain tumors are really common. That's why. They're the most common solid tumor in children. The only tumor that's more prevalent is leukemia. So we have approximately 200 cases each year diagnosed in Canada, so roughly 10% of those are in Alberta, so about 20 cases a year. And this year, for whatever reason, we're going through a real lull. I think we've only had 3 cases in the last 6 months, which is pretty wonderful. But in the 6 months before that, we had 15, so it really fluctuates up and down. And then, interestingly, are they on the rise? And certainly if we look at statistics, they are, but there was a significant blip in the increase in brain tumors diagnosed in 1984. And so there was something very specific that came about in 1984, and that was the advent and widespread use of MRIs. Okay, so it probably isn't the case that brain tumors are significantly increasing. They probably are increasing a little bit, but the fact that we're seeing more and more of them actually has to do with the fact that we're better recognizing some of the signs and symptoms, and we have better tests to look at them. What's important? Well, for me, the age of the patient is very important. I have a good sense as to what to expect from a kid and what not to expect from a child. And in treating kids, it contributes a lot to why we sometimes have a hard time diagnosing brain tumors. Because if you have a 2-month-old who's really fussy, is that just a fussy two-month-old? Or is there something else going on that we need to investigate? And so it's not uncommon for brain tumors to be there, to be symptomatic for many, many months before they're finally diagnosed. In fact, 6 to 9 months is pretty common for there to be a delay in diagnosis. The location, this red line demarcates the infratentorial space, or below the tentorium, which is along that line, from the supratentorial space. In adults, almost all of the tumors are up here in the cerebrum. In kids, the majority of our tumors are in the cerebellum and brainstem, and in the fluid spaces in between, within the fourth ventricle there. And so the type of surgical practice I have is very different than my adult partners who are dealing with tumors up here. But even though the majority of pediatric brain tumors are in the posterior fossa, if you break it down by different age groups, there's actually differences. So newborns actually have more tumors up top, but there's not a lot of newborns with tumors. Most tumors that we see show up between 3 and 10 years of age, and the majority of those, the vast majority of those are back here in the posterior fossa. And then once you get older again, you start shifting into the adult world and you have more tumors up top. This is a very large study out of the States looking at the rates of tumors based on age, and you can see that the real common tumors are here sort of between 3 and 8 years of age. We're still seeing a lot in that first 10 years, and then another little blip a little bit later. And the most common tumors are thankfully benign ones, and particularly as you get older and older, the tumors that we see are more and more benign. Early on, these tumors here, PNETs, the actual common one is something called the medulloblastoma that we'll talk about more later. And this one here is ependymoma, which is what this patient of mine had. And you can see that early on, they're actually making up about 1/3 of tumors, and then later in life, they're making up only 10 or 15% of tumors, which on the whole is nice because they are a very aggressive tumor. So what kind of risk factors are there? So certainly exposure to ionizing radiation can contribute to brain tumors, and in some countries, not North America, but in some countries they continue to use radiotherapy for treating ringworm of the scalp, and they have a significant increase in their rates of brain tumors. That therapy goes on over a course of time, and interestingly probably plays a significant role in the development of brain tumors, because if you look at the Japanese population after the Second World War, they actually didn't show a significant excess of brain tumors. They showed an increase in tumors overall, but not specifically of brain tumors. So a lot of it has to do with the specific dose, how it's applied, and where it's applied. But that single significant dose of radiation probably is less contributory to developing tumors than smaller radiation doses over time. But what is the real impact of ionizing radiation? Because one of the questions that the pediatricians often will ask me is, well, does this child really need a CT scan? And my simple answer to them is yes. If you're asking me, does my patient need a CT scan, you're obviously worried about that patient, and if you're worried, you should go the extra step and find out. Now that's easy for me to say because I deal with pathology all the time, and so when I'm getting CT scans, it's because I'm looking for trouble, and I can't do my job without pictures. So it's really easy for me to say, yes, get a CT scan. We are moving more and more towards MRIs. MRIs have different risks, specifically related to sedation. Actually, I have to put a kid asleep to get an MRI, and some kids, when you put them to sleep, they don't wake up. And so that's a significant risk that I'd rather avoid in the really young kids. So, but if you look around the room, quarter of you are going to die from cancer. Sorry, it's true. The additional risk only goes up by this much if you had a CT scan. So when I think about that additional risk, it makes it really easy for me to say to the pediatrician, yes, go ahead and get a CT scan. I've got patients in hospital right now who I would conservatively estimate have had 200 CT scans in their head. I could probably think that tomorrow he or she's having another one. Because I need pictures, it's how I do my job. So overall, a CT scan of the body increases your lifetime risk a small amount, and a head a very small amount. And if you think about the tens of thousands of people who die each year from cancer, it's estimated that perhaps an additional 500 people might ultimately die over the course of their lifetime because of radiation exposure from the CT scan, which when I think about all of the kids who I've seen that came to me too late, I couldn't help them, I justify that risk. So there are some reasons that I can blame the parents for their child's brain tumor, and it's these different genetic syndromes, most of which are passed on. Neurofibromatosis is passed on half the time it's a sporadic mutation where the child gets it from parents who were not carriers. The remainder are all genetically passed down, but only 5% of all the brain tumors that are seen actually come from one of these genetic syndromes. The rest are sporadic and have no familial relation whatsoever, but parents go through a period of self-blame regarding who they are and where they live and everything else because they want to take responsibility for this horrible diagnosis that the child has received. As I was saying earlier, in infants, the presentation is very non-specific, and you have to look kind of hard to find reasons to go ahead and do the CT scan or an MRI. Largely, though, you just look at a great big head, because brain tumors ultimately lead to a blockage of the normal circulation of spinal fluid within the head, and the head just gets bigger and bigger and bigger, and that's a really common presentation for us. The other one in the infant to toddler is the child who's failing to make developmental milestones because they're so nauseated because of this tumor that's in their fourth ventricle that's putting pressure on their brainstem and causing them to vomit all the time, and they just have very poor development. So young children are going to give you a little bit more information. They're actually going to tell you that they have headaches. They're going to also have nausea findings. They're going to perhaps make the early developmental milestones, and then they're going to plateau or they're going to regress. And then as the child gets older still, they're going to show you, look, I'm not as strong as I used to be. Or when I'm playing soccer, I'm having a hard time keeping up with my friends because I've got this tumor that's starting to grow inside my head and cause problems. So they're the kids who were normal and now we're starting to get worse. And so those are the ones where it's actually really quite easy to make the diagnosis relatively more easy. In general terms, kids with brain tumors need, and one of my partners, they need an operation. They need to have that tumor taken out. The role of radiotherapy and chemotherapy is limited, though essential. Radiotherapy first, has significant side effects when given to kids less than 3 years of age. And so when I'm seeing a lot of those tumors in those first 3 years of life, I've lost one of my options for treating that patient, which means more of the responsibility is on me. I have to do a good job. I have to get rid of that tumor because the radiation oncologists kind of have their hands tied. There is some newer literature that's suggesting that radiation therapy is beneficial in kids less than 3, but really that's in tumors where the kid's going to die without it. And so who cares what's going to happen to them 15 years from now? And they're going to have a hard time graduating high school because their IQ's been affected by the radiation therapy. Let's actually get them to grade school. And so you radiate them. And then chemotherapy has been used extensively, particularly in the very young population, in the hopes that it'll keep the tumor cells growing very slowly until radiation therapy can go in and really do the killing damage. And so chemotherapy is a huge area for future growth and research as we find more and more compounds that may have benefit in brain tumors. Hydrocephalus is a common complication that I see at the time of presentation. Those tumors that occupy the fourth ventricle, they're block the normal circulation of spinal fluid, and then just like a beaver dam, all of the water upstream builds up, and that's why they present with a head that's getting bigger and bigger, because the water pressure inside their head is causing that growth, and also causing some of that nausea and vomiting irritability. And so I need to take control of that water problem. Sometimes I can do it with medications. Often that's not enough, and I have to put in what's called an external ventricular drain, which is this small plastic tube that I put into a small hole in the skull, and I put it down into the lakes. And then more and more we're trying to get away from implanting things. And so there's this ventriculocystonostomy, and I'm going to show you the video of that in a moment. So these are the lakes that I'm talking about. Spinal fluid is actually produced by the choroid plexus. It sits right here in the lateral ventricles, as well as right here in the fourth ventricle. And CSF is being produced, and you make about 2 cups of CSF a day, and that spinal fluid circulates inside the brain in those lakes, exits from the fourth ventricle, goes all the way down the spinal column, all the way back up, and then bathes the surface of the brain, and the body ultimately absorbs those 2 cups a day. If I put a tumor right there, or fill the fourth ventricle with a tumor, you can imagine how that water can't circulate properly and it starts building up, and we have to alleviate that pressure. So an endoscopic third ventriculostomy is what I'll show you here. I've actually got 2 different videos that show the same procedure. One done by my partner, and that's this one, and then one done by me, and we do it in very different ways, and I kind of want to show you both ways. So this is a flexible and steerable endoscope that we've put into the ventricular system. We're passing it from the lateral ventricle into the third ventricle now, which is in the midline, and then we're changing the orientation of the camera there, which is rotate a bit. And let me put the hand out of the way. And then we pass, well, my partner does it this way, he passes this little catheter down and pokes a hole in the bottom of the third ventricle. Remember, if you think about the fourth ventricle has been filled with this tumor, I got to bypass that obstruction, and so putting this little hole here, and it goes down into a CSF space in front, which you'll see in a moment. So then my partner, he puts a balloon in, and inflates that balloon. This scares the hell out of me, so I don't do it this way. And then he's created this bigger hole, and then he's going to drive his camera down there, and we'll see the CSF space right in front of the brainstem. So there he is, driving through. And so these are the perforating vessels that are supplying the pons, part of the brainstem. The basilar artery is there, sitting right there, which is the main blood supply for the posterior aspect of the brain. And that's not the best scary video, so we'll move on to the even scarier thing that I do.
You end the show.